Welcome to our ODA2 video. We will be teaching you about the Jebsen hand function test.
The Jebsen hand function test is a performance measure assessment that assesses motor function of the upper extremity. There are 7 subtests, including writing, simulated page turning, lifting small common objects, simulated feeding, stacking checkers, lifting large light objects, and lifting large heavy objects. The equipment needed includes cans, a wooden board, bottle caps, pens, checker pieces, pennies, paper clips, spoons, and beans. This assessment can be completed in about 15 minutes for experienced users. Newer users may struggle and it could take around 45 minutes at the most. It costs around $300 US. It tests unilateral hand function, each hand separately, doing the non-dominant hand first. This is a norm-based assessment that can be used for ages 6 to 65 plus, but the normed scores provided are for ages 20 to 94. Some strengths of this assessment include it being at a 3rd grade reading level, there is an ease of scoring, and the results are objective. Some potential limitations are that the testing equipment can be pretty bulky, making it difficult to transport. It can be a time-consuming assessment, especially due to that transportation factor, and the price is a little high. Here is an image of the normed data from the Shirley Ryan Ability Lab. This information is used later on with scoring.
Each subtest is scored using the time and seconds taken to complete each task. The total score for this assessment is a sum of the times for each of the subtests. A lower score is equal to greater function. The maximum time allotted per subtest is 120 seconds, and you then compare the patient's times to the established norms. Jebsen measured the test-retest reliability of this assessment in patients with conditions such as post-poliomyelitis, stroke, CP, RA, burn, congenital anomaly, trauma, polyneuropathy, and severe degenerative joint disease. It was found to have excellent test-retest reliability for all subtests using the dominant hand, except for writing, and all subtests using the non-dominant hand, except for feeding and large light objects. It was found to have adequate test-retest reliability for dominant handwriting and non-dominant feeding and large light objects, and had moderate responsiveness 1 to 3 months post-stroke and 1 to 6 months post-stroke. This assessment was found to have excellent intra and inter-rater reliability. As you'll notice, the scores vary from 0.82 to 1. Criterion validity was measured in a group of patients status post-hand surgery. They were evaluated pre-op and then again 9 to 12 months post-op. The Michigan hand function test was used as a reference standard. It was found to have poor correlation with MHQ total scores for patients with RA, OA, CTS, and fracture, poor correlation with MHQ subtests for ADL, function, work, satisfaction for RA, OA, fracture, and CTS for work and satisfaction, and adequate correlation for CTS with ADL and function.
With this assessment comes some potential for bias. Some examples include practice effect. So if the client has already performed this assessment before, maybe they will remember some of the factors and that can make their score higher. The equipment may not always be culturally relevant to all clients, so scooping beans or stacking checkers may not be relevant for a client who has never seen those items before or have never really handled them before. Some clients may have comorbidities or confounding factors that impact their score. Some examples are hearing or visual impairment or cognitive impairment. If the therapist has performed this assessment on a client with a similar diagnosis before, they may already have some expectations of scoring in that way that could lead to bias. The theoretical basis of this assessment is biomechanical, since it's addressing hand function and upper extremity strength. The focus is on body mechanics and remediation of function and occupational performance. This approach assumes the client is able to regain ability through rehabilitation. Our client is Jamar Jackson Jr. The client is 54 years old, born on August 4th, 1967. He is a widowed male, and he was referred to our clinic due to left upper extremity weakness post-stroke.
Our client suffered a right CVA in September and was admitted to the hospital via the emergency department. He underwent a carotid endarterectomy after imaging showed a blockage in his right carotid artery. He was discharged after 2 days and transferred to inpatient rehab, where he stayed for 4 weeks and was discharged on October 18th. An occupational profile was completed that identified his prior level of function was independent in all ADLs, IADLs, and desired occupations. His dominant hand is his left hand. He currently works at Chrysler as an operations manager and enjoys his work. He is a passionate cook, and due to his wife's passing, he desires to regain independence in cooking for himself. He also reports problems with activity tolerance and is experiencing sadness and loss of meaning due to his inability to participate and engage at prior level of function. His diagnosis, therefore, is right CVA with left hemiparesis, atherosclerosis, and right carotid stenosis.
An activity analysis was performed with our client, asking him to make some spaghetti in the small kitchen in our outpatient clinic. Upon activity analysis, we found that the patient fatigues easily and was unable to complete the entire process without any breaks. The patient demonstrated weakness in the affected dominant left arm and attempted to do all tasks with the unaffected non-dominant right arm. The patient demonstrated intact cognition, being able to understand all questions and instructions as well as provide coherent responses. The patient also demonstrated intact swallowing, able to swallow all items provided during dysphagia screening.
Our treatment plan for this client is to perform the Jebsen hand function test in order to measure his unilateral upper extremity function. We will also perform the Berg balance scale to measure balance and fall risk. We intend to improve his quality of life through increased independence in the kitchen as measured through patient report, and improve his activity tolerance and standing during self-care, dressing, and cooking ADLs, as well as IADLs, through physical practice and energy-saving techniques. Here is a video performing the Jebsen hand function test in our mock evaluation. Here is a video.
Here's an image of the results of that mock assessment. You'll notice there is a spot for reassessment, which would be part of our future treatment plan. We will also be using the Berg Balance Scale as the additional assessment for this client. We will use it to assess balance and fall risk due to left lower extremity weakness because the client's loved ones are concerned about fall risk. The Shirley Ryan Ability Lab addressed reliability of this assessment through multiple citations of studies that looked into stroke patients, and the reliability was seen as excellent. Similarly, for validity, in multiple studies, the validity was seen as excellent as well.